Welcome back, everyone, to our Explainer series. Today, as your lead instructor for Decode Healthcare with Harshal, we are jumping right into part 52 of our 150-part IPDRG masterclass. We're going to be decoding the complex and honestly heavily audited coding rules for infectious diseases and mental disorders, really navigating the amazing architecture of the MSDRG system together. But real quick before we dive in, if you are enjoying this lesson, please like, share, and subscribe to this channel and share it with friends for this free course on Decode Healthcare with Harshal. Let's take a quick look at the agenda. We'll do an intro and recap, hit MDC 18 for infectious diseases, tackle MDC 19 for mental disorders, dive into CDI specificity, and then wrap up with a summary and a peek at our next lesson. All right, Section 1, Intro and Recap. Let's get grounded. So in Part 51, we master the intricacies of blood and immunological disorders, essentially the conditions that compromise the body's natural defenses. And that is literally the perfect foundation for today. Why? Because now we're looking at what happens when systemic infections attack those very same compromised systems. Moving right along to Section 2, MDC 18, Infectious Diseases. As we dive into this category, I want you to keep this absolutely critical question top of mind. What exactly separates a base DRG payment from maximum reimbursement when we're coding these complex systemic infections? Well, the answer lies entirely in your documentation specificity and how well you understand the clinical criteria. Our scope for MDC 18 includes some seriously high-volume diagnoses. We're talking sepsis, severe sepsis, septic shock, tuberculosis, and HIV/AIDS. Now, a quick heads up. For HIV, you can't just code it based on, say, a recurrent pneumonia. You need explicit provider documentation that the pneumonia is an HIV-related illness. And a quick warning on bacteremia. That simply means there's bacteria in the bloodstream. It's not necessarily systemic, and it is absolutely 100% not automatically coded as sepsis. Now, this is where it gets super interesting. The sepsis DRG hierarchy is split into 3 distinct payment tiers. Down at the base, you've got DRG 872 without a major complication or comorbidity, or MCC. But if you add an MCC, like septic shock, bam, you shift up to DRG 871. And at the absolute highest tier, DRG 870, your reimbursement drastically shifts if that patient requires mechanical ventilation for greater than 96 hours. So the real game changer here is following the strict 3-step sequencing logic. Honestly, if you get this wrong, your MDC assignment is going to be completely off. Always sequence the underlying infection first. For example, sepsis due to E. coli. Step 2, identify and code the severe sepsis or septic shock. And finally, Step 3, code the specific acute organ dysfunction, like acute kidney or respiratory failure. Think of it like a chain. Infection, systemic response, organ failure. 1, 2, 3. Easy to remember, right? Furthermore, your DRG partition within MDC 18 splits based on interventions. Medical sepsis management, like treating someone with IV antibiotics, stays securely on the medical side. But if you have a definitive operating room procedure, say a bone biopsy for osteomyelitis or an IND of a deep abscess, that single procedure pushes the entire case over to a much higher-paying surgical DRG. It's a massive difference. All right, on to Section 3, MDC 19, Mental Disorders. Let's pivot to the behavioral health side. Under MDC 19, we're dealing with pure psychiatric conditions. Think major depressive disorder, schizophrenia, bipolar disorder, and acute psychosis. These are totally unique because they dictate their own special inpatient psychiatric facility payment mechanics. Basically, they follow entirely different reimbursement rules than your standard acute medical care cases. Which brings us to a really vital distinction for us clinical coders: organic versus non-organic. You've got to differentiate organic conditions, like dementia or delirium, which are rooted in physical or neurological changes and grouped to MDC 01 for the nervous system, from the non-organic pure psychiatric diagnoses that strictly fall into MDC 19. If you mix these up, your principal diagnosis will route to the completely wrong major diagnostic category. Now, when it comes to psychiatric procedures, we completely ditch the standard medical and surgical sections. Instead, we use Section G of ICD-10 PCS. The first character is G. The second, for body system, is Z for none. The real heavy lifting happens in the third character, the root type. This is what tells us if the provider performed psychological testing, crisis intervention, or individual psychotherapy. Okay, Section 4, CDI and documentation specificity. Guys, the true financial impact of clinical documentation here is just massive. Check this out. In a vague scenario, just coding unspecified pneumonia yields a DRG relative weight of just 0.86. But by simply querying the physician to clarify that the patient actually has sepsis and linking their diabetes to ketoacidosis, the principal diagnosis changes to MDC 18, bumping the relative weight to 1.90. You're literally more than doubling the weight just from clinical specificity. But to achieve that specificity compliantly, you have got to strictly distinguish between explicit and implicit documentation. Explicit is exactly what it sounds like. The physician writes the actual words, severe sepsis or septic shock. We can code that all day. But implicit scenarios, that's where the provider documents an infection, like pneumonia, and an organ dysfunction, like acute kidney injury, but they never actually write the word sepsis. You cannot assume it. Actually, you know what? Let me rephrase that. You absolutely must send a multiple-choice CDI query to the physician before you can legally code it as sepsis. A huge part of framing that query correctly is understanding the shift in clinical criteria. We've largely moved away from the older Sepsis 2 SIRS criteria to the modern Sepsis 3 definition, which defines it as life-threatening organ dysfunction caused by a dysregulated host response. SIRS on its own, it's essentially no longer coded unless the provider explicitly links it to a localized infection. Truly understanding this shift is exactly how you build a query-proof chart that can withstand payer denials and auditor scrutiny. And that need for specificity applies just as strongly to MDC 19. Take a look at this real-world mental health case study of a 27-year-old male. Just documenting schizophrenia is definitely not enough to capture the true clinical picture. We need the specificity of the acute exacerbation, the exact nature of the hallucinations, were they olfactory, gustatory, tactile, and the explicit presence of active suicidal plans. This is what truly captures the severity of illness and risk of mortality for these behavioral health admissions. That brings us to Section 5, Summary and Next Lesson. Let's wrap this up. So what are our key takeaways for today? First off, never ever assume sepsis. Always secure explicit provider documentation. Second, absolutely master that 1-2-3 sequencing logic for systemic infections. Infection, sepsis, organ dysfunction. Third, make sure you can easily distinguish an organic delirium from a pure psychiatric MDC 19 diagnosis. And lastly, make sure your POA, present on admission indicators, are captured perfectly. If a secondary diagnosis like a deep vein thrombosis isn't flagged as present on admission, CMS hits you with a hospital-acquired condition penalty, and it cannot be used to increase your DRG payment. Next time, in part 53 of our Explainer series, we'll continue our journey through the DRG universe by tackling the complexities of MDC 20 and 21. We're going to be focusing heavily on substance use and dependence, as well as the notoriously tricky sequencing rules surrounding toxic effects, trauma, and poisonings. You won't want to miss it. And of course, if you are enjoying this lesson, please like, share, and subscribe to this channel and share it with friends for this free course on Decode Healthcare with Harshal. I'll leave you with this final thought to chew on. As you look closely at the documentation crossing your desk this week, ask yourself, are your charts truly query-proof, or is your facility silently leaving critical patient severity uncaptured on the table? Stay focused, keep querying, and we'll see you for part 53.